Good afternoon and welcome to HIT Policy Update with Dr. John Halamka, a webinar tweet chat combo from healthsystemcio.com, sponsored by athenahealth. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Campbell, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. Please, we encourage you to type in your questions as they occur to you. Leave the default set to all panelists and send them in. We will take those later in the program. And you can download the deck using the URL on your screen. It's at the bottom of most of our slides, and it's also being sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to go 30 to 35 minutes with Dr. John Halamka. Then we're going to hear from our sponsor, represented by Chris Taylor, Enterprise Accounts Strategy with athenahealth. And then we're going to have our Q&A. So without any further delay, I'm going to turn it over to our good friend and regular guest, Dr. John Halamka. Dr. Halamka, thanks for joining us.
Well, thanks so much, Anthony. And as you know, every time we do this, I say it's hard to believe the policies change fast enough to fill a webinar every quarter. But in fact, they do. And all you have to do is pick up the New York Times and say, what policies have changed in the last, say, 20 minutes to know what chaotic, disruptive change is going on, and I'm going to try to capture at least the themes of the last couple of weeks. You know, we'll look at HIMSS, what did we hear in the keynotes, what were the major new technologies, what was the hype and the reality in the booth. Then we'll go through what is ONC up to, and really what are folks in both HHS and CMS and ONC focused on, given all the other changes in the administration. They actually do have some consistency in those three agencies, so we'll look at that. And then we'll talk about the priorities of some of the new players. And although we, of course, just had a change in the Secretary of the Veterans Administration, you know, at the moment, it seems like there is going to be at least a quarter or two of predictability on the HIT policy front. So with that, let us begin. So at HIMSS, what did we see? So as we know, we actually had a keynote from Eric Schmidt, the former chairman of Alphabet, parent company of Google. And what did he tell us? He said, well, you know, so many of these issues that we face in healthcare IT are all about search. And if we just use the Google API for Health and send a very large corpus of data to Google, they will be able to solve many of these healthcare IT challenges, be it interoperability, analytics, population healthcare management, et cetera. Well, I think, you know, you could wonder, is it really all about search? I mean, maybe that's an oversimplification. But what did Eric tell us is probably true? In the world of, say, ophthalmology, an average ophthalmologist maybe looks at 10,000 retinal scans in a lifetime. Verily, this healthcare-related subsidiary of Google has 1 million retinal scans on file, and has built a number of applications, machine learning applications and interpretation applications from 1 million retinal scans. And you know the problem with machine learning and AI is it's a black box. It's pattern recognition, it's statistical, it's probabilistic. We don't really know what the machine learning is doing, but it has somehow recognized patterns in retinal scans sufficient to actually outperform humans. And what Eric said was, it's not that Google is smarter. It just has much more data. And so I think that's sort of the fascinating question. I don't believe that we're going to see humans displaced by machine learning and AI, but I certainly think they're going to be augmented. And what do I mean? Well, I was talking to my chief of radiology the other day, and he said, you know, when I was a resident, we would have maybe 20 images in every MRI scan to review. I just finished reviewing a single scan with 330 images in it because it had 3mm cuts, axial and sagittal reconstructions. No human can look at 330 pictures in any detail and make some coherent conclusion. So what we really need at this point in history is some augmentation. Not that, again, that these deep learning systems are going to replace human cognition, but to say, of those 330 pictures, you know, there is something a little funny in these 25, and then the human can focus on that. So what you heard from Eric, and you also heard from, you know, it's generally Google, Amazon, Apple, et cetera, is the scale of their operations, both their storage, their compute, their facility to exchange information, and to supplement that with tools will, because of sheer size, be able to move the healthcare IT industry forward. I think that's probably true. You know, I don't think it's all about search, but I certainly do think it is all about scale. We didn't hear a lot, Anthony, and I don't know if you did, about, you know, Amazon's secret projects and what it's going to be doing to, I don't know, disrupt the supply chain and provide devices and pharmaceuticals, or what JP Morgan and Berkshire and Amazon are going to do together. But I guess the reality of what I can say is, now that we've got AWS, S3, and some of their other services, there are a set of, we'll call them Lego blocks, that are available from Amazon that any innovator can glue together at very low cost in very short time to do something amazing. And let me give you an example of something we've done with Amazon. So, hey, Anthony, have you ever had surgery? You don't have to answer that question. It's a HIPAA violation. But let's say if you did, we actually need to have a consent on file before we open the scalpel. And how is that consent delivered to your doctor today? You sign probably some consent in an outpatient setting with a pen, and that's faxed to a surgeon or hospital. And guess what? They lose it a lot, right? But we can't open the scalpel until we validate that you have a consent. So we asked Amazon, hey, can you use the machine learning Lego block to listen to our fax traffic? And when you see a consent coming over a fax line, can you put a checkbox in our EHR using an API that says, yes, the consent was received, and then put a digital copy of that consent in the EHR under the right patient? And that actually works totally fine. So we've actually removed the manual paper pushing of humans and now have faxed consents going into the EHR, and it eliminates the cancellation of operating room procedures. So this is, you know, perfect. It didn't take us a year. It took us a weekend to do this kind of stuff, because Amazon says, oh, we got a machine learning component, we got an image recognition component. You just lift those and use them as you will. You script things together. Now, we also heard about some of the work that Apple's doing. You know, in iOS 11.3, there's going to be a standard Argonaut-compliant Fire API so that any patient can get their record from an episode of care as they're walking out of the office. And the initial deployments across 13 hospitals will include Cerner sites and Epic sites and Athena sites. So I know Athena's on the call today. I mean, imagine that the day that we get 11.3 released, you're going to have EHRs that are able to send your clinical summary directly to your phone without a huge amount of complexity, all using national standards. And think about that. You know, if Apple has produced 800 million iPhones, you suddenly have 800 million containers under encryption and biometric control held by the patient that can receive data. So, you know, I'll summarize this early sort of HIMSS, keynotes, and events of saying, you know, our EHR vendors are here to stay. Epic, Cerner, Athena, Meditech, eClinicalWorks, they're not going anywhere. But they're going to be augmented by a series of cloud-hosted services available from Google, Amazon, Apple, and that is going to fundamentally change the way we develop applications and interpret data. Now, just a quick other example of machine learning and AI. This is not, as I say, going to do diagnosis and treatment kind of stuff. This is a lot of it just very prosaic. We gave Amazon 1 million operating room records. And we said, hey, Amazon, now that Anthony needs his appendix out, can you tell us how much time we should give them in the OR? And Amazon can say, oh, yeah, Anthony's a young, healthy, no comorbidities kind of person who's also thin, and therefore, and good-looking, Anthony, you know, and
Thank
therefore,
Thank you for noticing.
We do not need more than 25 minutes for an experienced surgeon to remove his appendix. So we actually went live with that component, and we looked at 15 surgeons' workload, and we were able to free up 30% of their OR time just by sending historical schedule data to Amazon. So this is, again, theme over and over and over. It's augmenting the existing EHR with external services via APIs and cloud. Now, we certainly did see more and more mobile and more apps, some patient-facing, some provider-facing. But pretty clear that in a world that's post-meaningful use, that we're going to want to enhance the usability. Otherwise, we know that more than half of doctors want to quit because they are so disenchanted with the burdens of having to do data entry. So where you get these creative apps, whether it's Athena's More Disruption Please program, Epic's Orchard, Cerner's Smart on Fire, saw lots and lots of emerging, highly usable apps running on mobile devices connecting to the EHR. I really do believe cloud with this HIMSS has come to its own. I mean, the sense is cloud secure enough, reliable enough, and cost-effective enough that it's prudent to move there. I've been a CIO for 22 years. Do you think I want to wake up every morning whether or not a server's booting? I just don't. I would much rather push the Microsoft Tuesday updates to somebody else, and the maintenance of the power and the cooling and these sorts of things. And so I think there's this broad realization, whether it's infrastructure as a service, platform as a service, software as a service, that cloud is really the way we need to go. And CIOs basically become agents that do procuring of cloud-hosted services and the plumbing to integrate them, as opposed to provisioning hardware and software. And the era of on-premise hosting and software licensing is dying fast. Now, of course, we also saw interoperability. And I know somebody is going to ask a question, Anthony, if blockchain will solve all the interoperability problems in the world.
You didn't look, did you?
And me, no, I would never do that. But you know, Anthony, that I am now the editor-in-chief of a new peer-reviewed open access journal called Blockchain in Healthcare. And why did I agree to become the editor-in-chief of that? It's because I wanted to find the good use cases where blockchain might help us, but also describe where it won't. So at HIMSS, sure, we saw some blockchain, but interoperability mostly, as we'll talk about in a minute, focused on APIs. And, we'll keep using the old HL7, ADT, and lab RAD sort of stuff, and we'll use the CCDA, clinical summary sort of stuff. But with these new APIs, the notion that we can have a patient or a provider query data in real time and get the structured data elements in a highly predictable way is pretty powerful. And I would tell you, you're starting to really see this year the Argonaut open source FHIR specs disseminated into products and services, both apps and EHRs. And just a quick comment on blockchain. The use cases for blockchain that I saw at HIMSS and others I'm seeing in the industry are more about proof of work, proof of data integrity, because remember, blockchain is slow. I mean, it's 7 transactions a second if you're using Ethereum, as opposed to, gee, I move 22,000 transactions a second just in my EHR. Blockchain's never going to help so much with that. But it does help us do things like, this is a note that I wrote. I signed it. And maybe I put a hash in blockchain, and therefore I can guarantee the note's never been altered. There's data integrity. Nothing's been deleted from the medical record or altered. Maybe I can use blockchain as a means of saying, hey, Anthony, you came to Beth Israel Deaconess. I'm not going to say anything about the care. I'm just going to say you were there. And therefore, we can look to the blockchain to figure out where your records might be found. Or potentially, we have all issues in every state with consent. Could blockchain be used with smart contracts to hold information about your consent? And the answer is sure. I agree to share my data for these purposes with these entities. And that's in a public ledger, so it's clear what data exchange I've consented to. So sure, it's components. It's not going to solve all the issues. We have to be very tactical and understand its limitations. So hey, that was 3 days of hymns in just about 10 minutes. I saved you talking to 45,000 people. So what are we starting to see on the policy side coming out of ONC, CMS, and HHS? So at the moment, ONC is really focused on two things: 21st century cures and the Trusted Exchange Framework and Common Agreement, or TEFCA. And so TEFCA was something required in 21st century cures, which, if you remember, was a bipartisan piece of legislation at the end of the Obama administration. Everyone supports it. It all was good. Accelerate innovation and drug discovery, interoperability, get rid of information blocking, but it didn't really say how. So TEFCA has two sections. And see here, Anthony, I'm going to save them reading 40 pages of TEFCA in 2 slides. So the first part, which I think is actually very good, is the principles of trusted exchange. So, pretty straightforward stuff, like, of course, we should only use commonly available, well-proven international standards for content and transport and vocabulary, and everything should be done openly and transparently, and there shouldn't be silos of data hidden away, right? Patients and providers should be able to access data as is needed for treatment, payment, and operations, care coordination. We know that even if you have arch enemies across town, you shouldn't let competition, you shouldn't let politics get in the way of good clinical care coordination. We know that everything should be done in appropriately secure fashions with low levels of encryption and auditing to ensure data integrity and that privacy is respected. We know that it's certainly great for patients and families to be able to gather all the data about them and have a continuous health record on the device or app of their choice. Makes great sense. And we know that we need to understand certain aspects of data and metadata, like who is the patient and what data does it represent. And there's a lot of challenges because we don't have a national healthcare identifier. And I've written a lot about this. We need a nationwide patient matching strategy if we're going to effectively exchange data. So all of this was good, right? The sort of mom and apple pie policies, guidance. Where I think it gets into a little bit of trouble is in Section B, where then it enumerates the technologies that we need to use. It was so specific about what would be a qualified health information network and an organization that approves these qualified health information networks. And the rules got to be so prescriptive in Section B that I actually worry that it will impede innovation. Government is good at many things. Government can be a catalyst. Government can provide incentives and penalties. It can provide us some things like common privacy policies. And I'm not sure government is very good at specifying technology. And I think the private sector should be told, here are the goals. Here are the customer requirements. And now, private sector, you go innovate. Because some of the standards that were enumerated in Part B of TEFCA were invented in the 1990s, right? They're not these internet-friendly, mobile-oriented, cloud-encompassing API kinds of things. So, fine. If you read it, just assume that it's good to have guiding principles, rules of the road, and guardrails. But you hope that what happens over time is we have a more outcomes-focused approach, and the industry is given the latitude to implement those desirable outcomes as technology evolves and as customers demand. That's TEFCA. Well, let's look at some of the characters in Washington today, right? You know that Jared has been assigned Peace in the Middle East, American Innovation, and Interoperability. I mean, it does seem a little bit unusual, and I don't know, what do you think? Which of those three is hardest? I don't know, maybe Peace in the Middle East is easier than Interoperability, could be. And so it's fascinating, you know, his plate's pretty full. And, you know, he's very engaged, and I hear time and time again when people go to the White House to talk about healthcare IT that they're actually meeting with Jared. So he's carved out the time to focus on this issue. And so what does that exactly mean? Well, I don't know that he is necessarily going to put forward specific regulatory proposals. The current administration doesn't necessarily do that. But probably he will show an impatience that we all as an industry do a better job at making data liquid, especially around getting it to patients and families. And to that end, you heard I mean, one thing that did happen at HIMSS, but has happened more since then, is Seema Verma, our administrator of CMS, has said that data exchange going forward should be patient-centric, right, so that we should be able to have aggregations of everything about you, and that you should be able to have a copy of that. And if you want to forward it around, if you want to contribute it to a clinical trial or clinical research, you should be able to. And she announced the Blue Button 2.0 initiative. Now, if you remember, about 15 years ago, there was a meeting at the Markle Foundation, and Carol Diamond and a group of folks said, shouldn't it be easy to get your data about you, you know, kind of like pressing that blue button when you get a ticket at a parking lot, right? Should be that easy. And so what came out of that discussion was the Blue Button 1.0, which was a text file of basically claims data, explanation of benefits information. And that text file was okay, but just getting a text file, a blob of all of your claims, it's just not something you can do much with. So what Seema announced at HIMSS is the idea that Blue Button 2.0 would be an Argonaut Fire API with your structured data accessible via an OpenID OAuth authentication authorization mechanism, exactly what Apple has done in iOS 11.3 and exactly what so many in the industry are doing now with Smart on Fire and other fire demonstration projects. So that's good. You know, you'll probably see Blue Button 2.0 on top of the Medicare data set, giving patients access to all that Medicare data and presumably opening up avenues for new innovation. And she also signaled that meaningful use has kind of run its course, right? We've done what's necessary to get adoption. We now have more than 90% of hospitals and doctors using electronic health records. Do we really need to have multiple years of additional attestation? It's not going to really get you much. I mean, the stimulus is already spent. We're just in a penalty phase. So if we instead focus on APIs and patient-family engagement and building mechanisms for enhanced data liquidity, that's probably a better future than looking at meaningful use. And so who knows? We've already started to see some revision of quality measures by CMS. We've already seen delays in any reporting requirements for meaningful use. And so maybe we'll actually see that entire meaningful use construct disappear and be replaced by a new focus on interoperability. And Don Rucker, our national coordinator, is laser-like focused on 21st century cures because he really feels that's the charge of ONC. ONC's budget was re-upped for the same as last year. Originally was going to go from $60 million to $28. Now it's back to $60. So in the budget that Trump just signed, it is fully funded going forward. So one expects them to focus on TEFCA, 21st century cures, interoperability, reduction of information blocking, and they'll also be very supportive of the Government Accountability Office, the GAO, doing a study on the costs and benefits of a nationwide patient matching strategy. So you also hope 2018 becomes the year we finally develop a strategy for being able to match records across disparate EHRs so that the patients can truly have a longitudinal view. So hey, that's HIMSS. That's the Trump administration. And Anthony, I know you asked me to describe everything that Donald Trump is thinking. I did my very best.
Well, I think it was yeoman's work, and you've done it very well.
So let me turn it back to you.
Yes, thank you very much for that, and we're looking forward to our Q&A in a few minutes. But before we get there, we're going to hear from our sponsor, athenahealth, represented by Chris Taylor, who heads up Enterprise Accounts Strategy. Chris, thanks for joining us.
Thank you, Anthony. Thank you to Health System CIO, and thank you to Dr. Halamka. Anthony, just making sure you can hear me okay?
You sound fantastic.
Okay, great. Thank you. If you don't mind going to the next slide, I can take it from there. Great, thank you. athenahealth partners with hospitals, health systems, and medical groups to drive results in revenue cycle, clinical workflows, patient engagement, and population health. Since our inception, our vision has been to build the health information backbone that helps healthcare work as it should, and we're uniquely positioned to deliver a better healthcare experience because of the network we've built and continue to expand. But what does the network mean? What are we doing it for? Could you please go to the next slide, Anthony? Our purpose is to unleash our collective potential to transform healthcare. Next slide. So how do we do this? Well, to realize our purpose, we live by these three commitments. We live in relentless pursuit of open healthcare. We aim to be the platform where patients, providers, partners, data, and services are wholly connected, fueling unparalleled innovation. To do this, we commit to fluid exchange of information and resources, connecting everyone to the information they need. Second, we multiply intelligence. We believe the best results come from the insight of all. We will bring together knowledge from every interaction, expand it exponentially, and concentrate it where and when it's needed. To do this, we commit to surfacing the most relevant insights and sharing what we know. And finally, free people to do what matters. We aspire to make every human interaction more meaningful. We strive to remove the friction from our healthcare experience, liberating us to perform at our highest potential. To do this, we commit to removing work from medicine that does not require judgment, empathy, or clinical skill. I'm thinking of the imaging images, the scans that Dr. Halamka was mentioning earlier. I think there's real opportunity there. Next slide, please. Why does this matter? Well, 95% of physicians have experienced difficulty or delay delivering medical care because they didn't have access to their patients' health records. Next slide. Even inside the same organizations, only 44% of physicians report that they can actually share their patients' information, and it's taking its toll. Next slide, please. Over half of physicians report the symptoms of burnout. Next slide. And as Dr. Halamka mentioned, most physicians wouldn't recommend the practice of medicine to their children. To us, this is more than just numbers, it's personal. So I want to share a quick video with you that we shot at Thomas Jefferson University Hospital that will hopefully bring this point to life.
When people...
Well, we don't have sound, but what I can tell you that
respected, that they don't get the chance to...
I'm sorry, we have sound now?
That's when burnout occurs. I don't think burnout is because of being overworked. I think a lot of people work 16 hours a day in something they love, which they feel they're worth.
Did you have sound on that at the end, Christopher?
I did, yeah, that was great.
All right, I'm going to play it again. I'm going to play it again real quick.
Okay.
When people come to work and feel like they're a robot, that they're not being appreciated, respected, that they don't get the chance to improve matters, that's when burnout occurs. I don't think burnout is because of being overworked. I think a lot of people work 16 hours a day, something they love, which they feel they're worth.
Okay, go back to the deck.
Thank you. Yes, please. So I hope that that message resonated with everyone. The big takeaway for me is burnout is not about being overworked. It's about not being able to do your job well. It's about not feeling the sense of humanity in delivering healthcare. So thank you all again for your time. In keeping with the commitments of multiplying intelligence and freeing people to do what matters, we study the interactions and behaviors of over 100,000 providers on our network to try to understand and make public what drives capability for providers. As the technology leaders for your organizations, you are the innovators. You are the change agents of a better future in healthcare. I invite each of you to engage with us, whether by learning how we can support your organizations or by checking out athenainsight.com, our editorial platform, and signing up for our newsletter. I'm always available to answer your questions at chtaylor@athenahealth.com. Thank you.
All right, very good. Well, I want to thank our attendees for bearing with me on playing that video, and if there was an echo, which we hear from some of you, I do apologize, but hopefully you were able to absorb the point of that video, which was that doctors are certainly not afraid of working hard, but they want to feel that their time is being used valuably, and it was a very nice video. So, thank you, Chris. All right, questions for Dr. Halamka. Let's jump right in. Go ahead and send them in as they occur to you, and we're ready to go. Dr. Halamka, you had mentioned, talking about the cloud, you had talked about how we're are we beyond if the cloud is good, and like you mentioned, it's really a question of CIOs managing the cloud, maybe using multiple clouds with different vendors, integrating those clouds, moving things around. Can you just go into a little more depth about what it's about now in terms of being effective with the cloud?
Well, sure. So you can imagine it's about agility, it's about security, it's about cost. And so what do I mean? Today, Beth stores the records of 2 million patients, every medical record on patients in Boston from 1977 to the present. Anthony, do you have any idea where it's stored?
No.
Amazon. Why Amazon? Well, how many employees does Amazon have keeping my data secure and reliable? 50,000, right? So let's imagine something bad happens on the internet. I have 8 of the most talented professionals in security looking at Beth Israel Deaconess data on my side. Amazon has 50,000. Who's going to be able to fix it first? Right? And so this is the challenge, is that when you're looking at this need where we have 0 tolerance for downtime, when we need, data centers that go beyond a geography. I mean, to be honest with you, my board said, wait, today we have 3 triple replicated data centers with a recovery time and point objective it's wonderful, but it's all New England based. What if North Korea goes wacky, right? What are you going to do about that? And of course you could say, oh, well then we'd have bigger problems, but the reality is by using, as you say, a cloud or multiple clouds, these are geographically dispersed replications of your data and compute that'll provide you enhanced reliability and security, data recovery beyond anything you can do yourself. Now here's another strange thing for me to say about the cloud. I am sure that Health Systems CIO is an extraordinary employer. Beth Israel Deaconess is a great place to work, but our stock options are not so wonderful. And we don't have Herman Miller chairs, fish tanks, neon, or cappuccino machines. So how easy is it for me to attract and retain the best AI machine learning talent in the business? It's hard. So if you say, I am now, instead of going to invent these technologies myself, I'm going to have a cloud provider that is going to enable really straightforward coupling of my data assets in the cloud to other functions like machine learning, and they can hire these extraordinary people and ensure they scale. That ensures that I can focus on the business requirements of my customers instead of trying to hire and retain these young AI machine learning professionals. And finally, I'll say that, I have 22,000 employees, and yet in my multi-billion-dollar healthcare system, my licenses for Microsoft products are still more expensive through me than through a cloud provider like Amazon. So more reliable, more secure, better retention of talent, lower cost. Seems pretty reasonable to do that.
And is that enough for a business case? Is that a business case?
Oh, and my board said I better do it. How about that?
Okay. I mean, could you have a board that was reluctant to do this type of thing and wanted sort of a hard ROI business case?
Well, and so in my case, what does a board care about in healthcare? They care about reputational loss, right? So if you spill data, or they care about the agility, the innovation, the ability to stay competitive and attract patients and keep patients. And so it would be hard-pressed for me to imagine a board, especially of non-healthcare professionals. Most of my board are folks from the financial services industry or retail, and they moved to the cloud years ago. So they tell me things like, it's a risk mitigation strategy. It is a mechanism by which, patients and providers will achieve better usability. You'll be able to move faster. And so, depends on, I suppose, what your metrics for business case are, but if it's safety, quality, cost, strategic alignment, it certainly hits all those elements.
Okay, very good. What are the chances we get a nationwide patient ID?
Notice that I was extraordinarily constrained in my description. I said nationwide patient matching strategy. And why did I use those weasel words?
You're going into politics, no?
Well, it's because I travel the world, and I know some societies are completely fine with the idea of at birth giving you a number that will track your healthcare data throughout your life. If you were born, I know this is going to be a test for you, Anthony. It's going to be hard. If you were born in Norway today, what would your national patient ID be? It would be, right, 2018-03-29-0001, 2, 3, 4, right? It's the date and your birth order. Seems pretty straightforward. But imagine America as 330 million fiercely independent folks who don't want anyone to tell them what to do or to control their data. It's hard. It's a cultural challenge.
Right.
So I think, there's maybe a couple of ways we might go. We could say, you got a TSA pre-check, right? Because it makes travel easier. How about a healthcare pre-check? Voluntary, right? You sign up for it. Give us your fingerprints. Give us your demographics. You don't have to have one. It's voluntary. That's one kind of nationwide strategy. Or here's another one. I hear startup pitches every day, and one that I heard recently, which is pretty reasonable. Now, Anthony, well, maybe you're called Tony, maybe you're called, who knows what, so your demographics aren't totally reliable, right? But hey, was your dad named Fred? No. Oh, okay. Well, the fact that I actually know where you've lived, who else has lived there, what car you bought, what property tax you pay, all this other stuff that's a little bit outside of healthcare, that in combination could be referential data that makes the name, gender, date of birth match a whole lot better. And I don't know, if you ever used Intellius or Spokio or any of these other kinds of services on the web, what you see if you're searching for that high school buddy long lost is you find eventually that person by looking at the other facts you know about them. Oh yeah, I remember their mom's name was Jean. Oh yeah, I remember they lived in this city back in the 70s. And so that might be a strategy. And then one of my favorite, and one that I'm working on a lot these days, is biometric. And in South Africa for the Gates Foundation, we had to match the HIV data, 65 million patients across the country, and we deployed iris scanners. And the idea is we'll simply tag your lab data with some hash of your iris scan. So when you come back into clinic, we'll be able to say, oh, we've seen these irises before, and here are the lab tests associated with them, and the doctor and the patient have now fluid access to every test done anywhere in the country based on iris scan tagging. And that's a strategy. And sometimes we do multiple biometrics. There may be people without irises, lost their eyes. So we'll do fingerprint and iris or palm vein geometry or other things. And we stay a bit neutral to the evolving biometric technologies. So long answer, but I think yes, we must as a country articulate the guidelines and principles of matching data in a consistent way for high, false, well, we'll call it positive predictive value, that we know it is really you, if we're going to have a coordinated healthcare system.
Very good. You had mentioned the idea that EHR vendors are not going away, but that they're going to be augmented. Do you have to be willing to be augmented? Do you have to be in an augmentable frame of mind? And I would imagine if we have a spectrum, we're going to have some EHR vendors that are more open to becoming platform-like with apps being plugged in, and some that are less inclined to do that and play nice in the sandbox. My guess is you're going to say if you're not open to other people sort of enhancing what you have, you're going to be in trouble. But I'll let you answer that.
Well, right, and there are 750 certified products that exist in the marketplace today. So when I said the EHR vendors aren't going away, what I meant is, Cerner, Epic, Athena, Meditech, eClinicalWorks. I mean, it's sort of like, a lot of these core vendors, because we are always going to need transaction engines to get the bills out and to be compliant and meet with all those Medicare and Medicaid regulations. So they'll be there. And you're totally right that unless they provide an ecosystem of innovation around them, enable patient data access through apps and these kinds of things, then they won't survive. And that's why I think a lot of the smaller niche players will actually disappear because they don't really have that mindset, exactly as you said.
Very good. Next question. How do you think the newly announced program, My Healthy Data, will fit into the interoperability landscape? Are you familiar with that?
Yeah, and that was the Blue Button 2.0 discussion I was talking about.
Okay.
Yeah, and so the idea being it's, so let me just riff on that for a second. My mother is in her late 70s. And I said, hey, Mom, do you know you'll be able to get your JavaScript object notation, structured data elements through an OpenID OAuth framework? And she, of course, looked at me like, huh? And what she said, and quite honestly, was, I think it's wonderful that you, John, can be the steward of my healthcare data. And as the family care navigator, I will delegate that authority to you. Now, I don't want a copy of my data. I don't have any intent of getting an app on my phone and being the steward of my data and managing it, but you should do that on my behalf. So here's where I think it's going to be interesting. I think patients and families are more engaged than ever before and want their data more than ever before, but it's going to require thoughtful delegation of who acts on it. And it will either be family members, like me, I would do my mother's or my wife's or my daughter's, or you might even see third-party services that evolve that are doing care navigation. We are the care traffic controller for your family. Delegate access to My Healthy Data APIs to us. So I think it's good. It won't solve every problem. There's still going to be provider-to-provider data exchange, but more patient-family engagement is good.
Very good. All right. The whole J.P. Morgan effort was interesting the way it came out, and then if you recall, at least from my recollection, some of J.P. Morgan's banking clients that had been very good customers of it thought they were going to be negatively impacted by some of the things coming out of here in terms of competition, and then it was all kind of scaled back a bit. Take me through your thoughts on the overall announcement, implications, and then if you were aware of that dynamic too, and if you found that interesting.
Yeah, I don't think we quite know what it is yet.
Yeah.
And so as we've been talking about the scale of an Amazon, the financial resources of a J.P. Morgan and Berkshire will enable disruptive innovation of some kind. And maybe it's that we're going to disintermediate some insurance companies, and maybe we're going to provide unique opportunities, starting with some cohort like Amazon employees for, I don't know, we'll call it employer-funded health plans that focus on wellness using unique tools that help you eat less, exercise more, and generally have a better lifestyle. And maybe if we did that, your total medical expense will go down. So again, it's a little, I think it's early, but all I can tell is those three companies are impatient and have the resources necessary to try these things. And just as we see with, Amazon's testing markets where you walk in and take stuff, you probably won't know if it works till you try it. So let's try it. And if we fail, that's okay. There'll be some learning had. So I look forward to that initiative as just a real opportunity to learn.
Very good. All right. Well, I think that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could answer that, we'd appreciate it. Regarding continuing education, with the CHIME CHCIO certification, gets you 1 CEU attending our webinars. And if you need a certificate for another CEU program, you can use the final slide in this deck. You will receive an email when our archive recording has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox on our team, and you can go to our website to view our upcoming schedule of events. So with that, I want to thank our speakers today, Dr. John Halamka, Chris Taylor from athenahealth, and I want to thank that company very much for sponsoring this event and making it possible to get this great information out. I want to thank you, our attendees, for always showing up. And with that, everybody have a wonderful day. Thank you.
Thank you.